So now we had seen about the features of malignancy. Next, we'll move on to the most important thing, which is hallmarks of cancer, which is also called as fundamentals of neoplasia. So we have 8 hallmarks of cancer. Then to that, they have added 2 new things in the new Raubens 10th edition. That is enabling characters. They are calling it as enabling characters, which is cancer promoting inflammation and genomic instability. So what are the hallmarks of cancer? It is self-sufficiency of the growth signals. So the tumor cells are not dependent on the growth signals for their proliferation and growth. So without them itself, they can grow by themselves. So that is self-sufficiency of growth signals. Then we have insensitivity to the growth inhibitory signals. That is, they do not respond to a stop signal. They keep on growing on their own. Then altered cellular metabolism. So they don't use the normal cellular metabolism, they use some other metabolism for and that helps in the tumor cell growth. Then they have evasion of apoptosis. So apoptosis will actually kill the tumor cell, right? So in order to escape from the tumor apoptosis, the tumor cells are going to have engage some mechanism so that they can evade from the apoptosis. Then limitless replicative potential. So they are going to attain immortality. Then sustained angiogenesis. So in order to grow and spread, the tumor cells are going to need blood supply. So they are going to develop some mechanism in which they are going to have a continuous sustained blood supply. Then invasion and metastasis. So only when angiogenesis is there, they can invade the blood vessel and the local tissue and grow into other local surrounding tissue and also go into metastasis, so to distant sites. So for that also angiogenesis is needed. Then normally the host immune cells will actually attack the tumor cells and kill them, right? So the tumor cells have to escape from the normal immune cells to survive. So evading the immune response. So these mechanisms, these 8 mechanisms are called as the hallmarks. And then there are enabling characters that is going to help in the tumor cells to grow. So that is cancer promoting inflammation. So basically the tumor cells are going to induce the inflammatory cells and then make them work for it. So make them work for it, that they are in a way that it helps the tumor cells to grow and escape from the immune cells. Then lastly, we have genomic instability. So normally DNA repair is going to be altered in this tumor cells. Okay. So when this DNA repair is not happening properly, it is going to result in lots of genomic instability. Okay. So all of this is again going to cause tumor and mutations. Okay. So let's see one by one. So first one will be self-sufficiency of growth signals. Okay. For self-sufficiency of growth signals, we'll need to understand some pathway. So normally for growth to take place, what happens is there will be a growth factor. This growth factor is going to come and attach to its receptor, which is the growth factor receptor. This growth factor receptor will in turn get activated and that will induce the activation of certain signaling pathways. So signal transducing proteins will be activated and that will in turn go, and these signaling proteins will go in and cause the activation of certain nuclear transcription factors. This nuclear transcription factors will in turn act on the cell cycle regulators and cause the cell cycle to progress. So when cell cycle progress, the cells will start proliferating, right? So this is the normal thing which happens. So each of this growth factor receptor, signal transduction proteins, nuclear transcription factors, cell cycle regulators, all of these are actually called as proto-oncogenes. That is normal. But when these are going to be mutated, they can result in increased proliferation, right? So gain of function of any of these 5 classes of proto-oncogenes is going to result in the increase in the growth of the tumor cells, proliferation of the tumor cells, so survival of the tumor cells. So when the mutations of these 5 classes occur, they are going to be called as oncogenes. Okay, oncogenes is gain of function of these proto-oncogenes. Okay. So let's see the examples. So starting with growth factors. So growth factors, some of the growth factors along with the cancers they cause we'll be seeing. So HGF is hepatocyte growth factor. Hepatocyte growth factor, as the name suggests, it is going to result, the gain of function mutation is going to cause hepatocellular carcinoma. Then PDGFB, which is platelet derived growth factor B. Here it is going to cause astrocytomas. HST1, here the mutations are going to result in osteosarcomas. Then we'll see the second class of oncogenes, which is growth factor receptors. So ERB1 is nothing but EGFR only. So EGFR mutations you usually see in lung adenocarcinomas. In fact, we have targeted chemotherapy for targeted therapy for this EGFR. So we can give erlotinib, geftinib when the EGFR mutation is being detected. Okay. So EGFR is mutated in lung adenocarcinomas. Then ERB2 is going to be HER2. So HER2 amplification, we see it in breast cancers. Then gain of function mutation of a RET gene, RET oncogene is going to be seen in medullary carcinoma of thyroid. In fact, we see the same gene mutated in the MEN2 syndrome also, right? And then we have PDGFRB. Again, like PDGFR growth factor, it is again going to cause gliomas only. Then KIT mutation, KIT is also called as CD117. So this is going to be seen in gastrointestinal stromal tumors and also in seminomas. Then ALK mutation, here ALK mutation is going to be seen in neuroblastomas, then anaplastic large cell lymphomas, which is a T cell lymphoma actually. And apart from that, you are also going to see this in lung adenocarcinomas. So examples in this fundamentals of neoplasia is going to be important. So we'll have to learn it. So these examples along with the genes are important here again. So the next class of oncogene will be the signal transduction proteins. So the first example will be the RAS. So RAS is in fact the most common oncogene which is being mutated in human cancers. So look at the question carefully. If they ask about oncogene, it is going to be RAS. If they ask generally if most common gene mutated, then it is going to be P53. Okay. So RAS, we have three classes of RAS mutation, which is KRAS, HRAS and NRAS. The KRAS mutations are going to be the most common ones. This KRAS mutations, we usually see it in pancreatic carcinomas, stomach, colon and even lung cancers. Okay, KRAS mutations. HRAS mutations you usually see it in kidney cancers and then bladder tumors. Okay, NRAS mutation you are going to have it in melanomas and also in acute myeloid leukemias. AMLs and melanomas you are going to have NRAS mutations. So when we are seeing about this thing, I'll tell what happens in the RAS pathway. So when a growth factor is going to get attached to its growth factor receptor, it is going to activate the signal transduction protein, which is RAS. So inactive RAS is going to get converted into active RAS with the help of forming GTP. So GDP is going to be converted into GTP in this reaction for producing an active RAS. So this active RAS will enter into the MAP kinase pathway, and the MAP kinase pathway will stimulate the cell cycle, and the cell cycle is going to progress, causing the proliferation of the cells. So this is normal. So when this RAS is going to be activated, this active RAS is going to be in a constitutively active state. So RAS mutation is going to make the RAS to be constitutively active, so that cell cycle is continuously progressing. Okay, there is something called as a gap protein. So gap proteins are nothing but GTPase activating proteins. So these gap proteins will actually, as the name suggests, going to activate a GTPase enzyme. So this GTPase enzyme is going to convert the GTP formed into the GDP. So when GTP is getting reconverted into GDP, the active RAS will in turn become the inactive RAS, and thus cell cycle will stop. So this is what happens normally. But when there is this active RAS mutation, this is going to be altered. There is also mutation of this gap protein. So gap proteins are, if you see, their normal function is to stop the cell cycle, right? So they are actually not oncogenes, they are tumor suppressors. Gap proteins are usually tumor suppressor genes. So this gap protein, example of this gap protein is going to be a neurofibromin. Neurofibromin, which is NF1, right? So this NF1 is a gap protein actually, which is going to inhibit the activation of this RAS. So it is a tumor suppressor. So this mutation is going to be loss of function mutation. So whenever this gap protein's loss of function mutation, which is a tumor suppressor gene, loss of function mutation is there, it is again going to cause tumors. Okay. So the second signal transduction protein, which is an oncogene, is a ABL. So ABL, we had seen it already a number of times. It is involved in the translocation 922, which we see in chronic myeloid leukemias. So, which will result in the fusion of BCR-ABL. This BCR-ABL is going to activate a tyrosine kinase. So, tyrosine kinase activity is going to be increased. That will result in cell proliferation. So, if we inhibit this tyrosine kinase activity with certain drugs called as tyrosine kinase inhibitors, example of which will be imatinib mesylate, you can stop the proliferation of this cells. So, this is what we call it as oncogene addiction, meaning the entire CML is actually dependent on this increased tyrosine kinase activity. Okay, the proliferation is entirely dependent on this tyrosine kinase activity. And if I am blocking this with the tyrosine kinase inhibitor, the proliferation of the cells is going to get stopped. So, that is why CML we are going to have it is a curable, treatable kind of a leukemia. So, this is why it is called as oncogene addiction. That is, this tyrosine kinase activity is needed because of the BCR-ABL fusion. The oncogene is needed for the disease to progress. This is what we call as oncogene addiction. So, the third signal transduction protein will be BRAF. So, BRAF is again a oncogene. So, we have seen BRAF mutation many a time. So, let's list the examples of BRAF mutations. So, firstly, we saw it in hairy cell leukemia. So, in hairy cell leukemia, you are going to have 100% of this BRAF V600E mutation. Then we have nevi. Nevi are nothing but mole, right? Nevi, you are going to have 80% of this BRAF mutation. Then we have melanomas. Melanomas, you are going to have 60% of this mutation of BRAF. Then we have Langerhans cell histiocytosis, and also in some forms of colonic cancer also you are going to have BRAF mutations. Okay, so these are again examples. They are, in fact, they have asked this percentage also. Okay. Then the last signal transduction protein is a JAK2. So JAK2 gain of function we are seeing it. We are seeing it in myeloproliferative neoplasms like polycythemia, essential thrombocytosis, and then we are also seeing it in myelofibrosis. So there again we are going to see JAK2 mutations. Then moving on to the next class of oncogenes, which is nuclear regulatory protein. So nuclear regulatory protein, the most important one is the MIC protein. So MIC is again classified into three types: C-MIC, L-MIC and N-MIC. So C-MIC is the one which is involved in Burkitt's lymphoma. If you remember, in Burkitt's lymphoma, we have various translocations, all of which is going to involve the chromosome 8, because chromosome 8 is the location in of this C-MIC. So in Burkitt lymphoma, we are going to have 822, 814, 28, these kind of translocations, right? So all of this is going to be because of the C-MIC translocation. Then L-MIC. L-MIC is going to be seen in small cell lung cancer. So lots of L's are there in this. So small cell lung cancer for L-MIC. Then N-MIC is for neuroblastoma. So N for N. Okay. You even see this N-MIC amplification in medulloblastomas as well. So NM you can remember, neuroblastoma. And in N-MIC, N-MIC is actually a very bad prognostic factor for neuroblastoma. So in neuroblastoma, N-MIC amplification you'll have to check for. Same for medulloblastoma also. They'll ask for this N-MIC amplification, which is going to be a poor prognostic factor in both of these tumors. Then the last class of oncogene will be the cell cycle regulators. So in order to understand this, we'll first see what is the cell cycle. So in a normal state, the cells are going to be in a quiescent state. Okay, so the quiescent state is going to be the G0 phase. So after that, when you get a growth factor stimulus, the cells are going to enter into the pre-synthetic phase, which is the G1 phase. So the time period for which this G1 phase and G0 phase is there, it is going to be quite variable. So after entering into the G1 phase, the cells will then go into the synthetic phase or the S phase. So in the synthetic phase, there is going to be the production of the cells, right? So that is what is called as synthesis. So it is going to be taking place for a time period of 6 hours, and this is S phase is called as the point of no return. So once it has entered into the S phase, it is going to complete the cell cycle. There is no going back. Okay, so this is called as the point of no return. So after the synthetic phase, they'll enter into the G2 phase, and after G2 phase, which is the post synthetic phase, it is going to enter into the mitotic phase. So synthetic phase is for 6 hours, then G2 phase is for 4 hours, then mitotic phase is for 2 hours, okay, divided by -2 for each of this, 6, 4 and 2, okay. Usually this G1 to S phase is going to be having a checkpoint. So just to check that everything is happening normally. So we are having a checkpoint which is the RB gene. So retinoblastoma protein is the one which is going to have cause the checkpoint in the G1S transition. While in the G2M phase, it is the P53 protein which is going to cause the checkpoint in G2M. Okay. So whenever this cell cycle is happening, you are having certain other factors called as the cyclins and cyclin dependent kinases. So the cyclins and cyclin dependent kinases are again proto-oncogenes. So when these cyclins and cyclin dependent kinases enter into the cell cycle, they are going to promote the cell cycle. So cells proliferation is going to happen. So what actually happens is the first cyclin which is going to enter is the cyclin D along with its cyclin dependent kinase 4 and 6. CDK is cyclin dependent kinase. So cyclin D is going to associate with two cyclin dependent kinases, which is CDK4 and CDK6. Together, this complex is actually going to come and phosphorylate this retinoblastoma protein. So when retinoblastoma protein is being phosphorylated, what happens is retinoblastoma protein is getting inactivated. Normally, if you see everywhere, phosphorylation is actually causing activation, but here phosphorylation is actually causing the inactivation of the retinoblastoma. So retinoblastoma protein is getting inactivated. So what happens is normally this retinoblastoma would have caught up with a protein called as E2F. So elongation factor. So E2F is there. So when this elongation factor and retinoblastoma is together, this is going to stop the cell cycle. It will not let the cell cycle to progress. So this is the normal function of retinoblastoma. But when this cyclin D has come in, cyclin D along with the cyclin dependent kinase 4 and 6 has entered and caused the phosphorylation of this retinoblastoma, the retinoblastoma protein is going to become inactive, and whatever elongation factor was attached to it, it is going to let it go. So the E2F is going to be released. So the E2F is going to release, and then this E2F will enter into the cell cycle, causing the cell cycle to progress. Okay. Understood? So I will write it again here. So cyclin D and cyclin dependent kinase 4 and 6 will come and phosphorylate this retinoblastoma. When turn, this E2F which was attached with the retinoblastoma protein will exit and enters into the cell cycle, causing the cell cycle progression. Okay. Other than that, we have various other cyclins and cyclin dependent kinases as well. So let's see that one by one now. So as I mentioned, G1S checkpoint was controlled by the retinoblastoma protein, and G2M checkpoint, which is the most radiosensitive phase actually. Okay, it is going to be controlled by the P53 protein. So regulation of cell cycle, we saw it is going to be by the proto-oncogenes, cyclins and cyclin dependent kinases. While RB and RP53, these are actually the checkpoints which are inhibiting the cell cycle. So these are actually tumor suppressors. These two are tumor suppressors, while these cyclins and cyclin dependent kinases which are promoting the cell cycles are going to be proto-oncogenes. So when they get mutated, they form oncogenes. Okay, so the cyclin D is going to associate with cyclin dependent kinase 4 and 6, while cyclin E is going to associate with cyclin dependent kinase 2. Then cyclin A is going to associate with a cyclin dependent kinase, both dependent kinase 2 and 1. Then cyclin B is going to associate itself with cyclin dependent kinase 1. So if you write it like this, you will be able to remember DEAB for the cyclins. Then the first and third is going to have two numbers. Okay, so 4, 6. Then minus 2 will be 4 minus 2 will be 2, and then you'll have again 2 and 1 here, and then again minus 1 you are going to have 1. So 4, 6, 2, 2, 1 and 1. So write it in this order so that you don't get confused. So in this, if you see, the cyclin dependent cyclin D and cyclin E along with their cyclin dependent kinases, these two are going to act upon the G1S phase. While the cyclin A along with this cyclin dependent kinase 2 and 1, it is going to act on the synthetic phase. While cyclin B along with cyclin dependent kinase 1 is going to act on the G2M phase. So this again is important. So now we had seen about the cell cycle progression. We have something called a cyclin dependent kinase inhibitors also, so that they keep a check again. Okay, so like retinoblastoma and p53, these are again going to cause a check to the cell cycle progression. So we have two basic families of cyclin dependent kinase inhibitors, which are CYP family and then INC4R family. Okay, CYP family usually inhibits all, it is going to inhibit all the cyclin dependent kinases, while INC4R family is going to be specific and they are going to inhibit only CDK4 and 6. That is the first one, which first cyclin dependent kinase, which was associated with the cyclin D, right? So only CDK4 and 6 is inhibited by the INC4 family. So under the CYP family, we are going to have three proteins, which is P21, P27 and P57. So this P21 is in turn actually regulated by the P53 only. Okay. And then INC4 family, we are again dividing into P16 INC4 family and then P14 ARF family. So under P16 INC4 family, you are going to have P15, 16, 18 and 19. Leaving 17, all the four are there, 15, 16, 18 and 19. Okay. And then P14 ARF4 is going to encode for P14 as the name suggests. And this function of P14 is to inhibit the MDM2 protein. So normally MDM2 protein is going to cause degradation of the P53. So MDM2 normally causes degradation of P53, but when P14 is there, it is going to inhibit MDM2 so that P53 is going to be active. Got it? So let's see the mutations associated with the cell cycle regulators. So this was the topic proper actually. So we were seeing about the cell cycle now. So cell cycle regulators, which are the cyclins and cyclin dependent kinases, are the actual oncogenes here. So the mutation of cyclin D1 is going to be seen in mantle cell lymphoma. So mantle cell lymphoma, we are going to have translocation 1114. So in this, we are going to have cyclin D1 mutation. Then cyclin dependent kinase 4 mutation is going to be seen in glioblastomas, melanomas, and also in osteosarcomas. While P16, which is actually belonging to the INC4 family, right? So the gene for them is actually called as the CDKN2A gene. Okay, the CDKN2A gene, which encodes for this P16, is going to be mutated again in glioblastoma and melanomas.